Our first speaker is Dr. Rocky Bilhartz, a cardiologist and blogger. Dr. Bilhartz is a graduate of Rice University and received a joint medical doctor, MD, and Master's of Business Administration degree with specialization in health organizational management from Texas Tech University Science Center. He completed postgraduate medical training in internal medicine, cardiovascular disease, and interventional cardiology at Texas A&M University Health Science Center, Scott and White Memorial Hospital. He is going to be talking to us today about government takeover of quality in medicine. The quest to improve real quality in medicine has taken a setback in recent years due to increasing government involvement. Although Americans have always maintained a fierce defense of freedom and a healthy skepticism of government, it now appears that more skepticism should have existed regarding our government's ability to define, collect, and measure quality variables in healthcare. Dr. Bilhartz will briefly touch on the challenges that exist in this environment and the solutions which actually appear to be much simpler. Dr. Bilhartz, thank you for joining us today. We look forward to hearing your presentation.
Quality in medicine has been evolving for several millennia. Around the 4th century BCE, before the Common Era, it was arguably first spelled out in a collection of approximately 60 treatises, known as the Hippocratic Corpus. These outlined diagnostic methods of physicians, but they also detailed treatment failures for the benefit of all. The Corpus's most famous surgical text, On Fractures, opens with a promise to discuss mistakes. I must therefore mention which of the physician's mistakes I want to teach you not to do. Life is short, the art is long, opportunity fleeting, experiment perilous, judgment difficult. This is one of the most famous statements of the Hippocratic Corpus. You see, the quest for quality throughout the corpus was a personal matter. It was centered on humility and the challenges of medicine. There was less of a focus toward a world group or even professional responsibilities. Now, 1,000 years would pass throughout the Middle Ages, and the relationship between medicine and church was strong. The body and the soul were viewed as one. The body, that physical object that can be touched and measured, and the soul, that intellectual, willful being that is less easily grasped. These two entities, though, were one and the same, and quality depended upon being able to treat these together. But by the start of the 16th century, this would change, or our view of medicine would change, or rather our Western view. It would become more of an empirical science than an art. Nothing matters that can't be measured or quantified became the new mojo. And since the soul couldn't be grasped, it had to be separated out. In fact, our focus shifted almost entirely toward the body as medicine became a science. Our body was now a machine for observation and experimentation. You want to fix the patient. You got to fix the defect, and it'll fix the machine, and then find a way to standardize the operation. By the 19th century, medicine was being performed more within institutions. And the new hospital work environment further molded responsibilities away from the individual, away from the Hippocratic emphasis on personal humility, and more toward group responsibilities. Professional ethics, medical professionalism, tracking this, tracking that. And these concepts by themselves, they weren't bad things. They likely arose, at least in part, from our inherent will to constantly improve things as human beings. As this quest for quality entered the 20th century, medical education received what appeared to be a much needed overhaul regarding qualifications for entry. The Food and Drug Administration was established, setting standards for prescription medicines. By the 1950s, several organizations joined together, including the American College of Surgeons, the American College of Physicians, the American Hospital Association, the American Medical Association, and the Canadian Medical Association to form the Joint Commission on Accreditation of Hospitals, now simply known as the Joint Commission. And all this was done in the name of improving quality. In essence, modern evidence-based medicine was born. Basically, the concept that statistical evidence gained from a finite few can be used as standardized therapies for populations of people. By the mid-1980s, Congress had created the Agency for Healthcare Policy and Research, now the Agency for Healthcare Research and Quality, which in part was formed to create clinical practice guidelines that could guide physician decision-making, standardize practice, and then improve healthcare quality. Population-based medicine, essentially what's good for the group is good for the individual, would become the cornerstone of managed care, with the overriding emphasis on cost containment and access to massive amounts of data. In 1996, the Institute of Medicine would unveil an initiative to improve the nation's healthcare quality, and then at the turn of the 21st century, it would release its magnum opus, To Err is Human, building a safer healthcare system, which summarized earlier findings regarding medical errors. This report famously alleged that as many as 98,000 Americans die every year due to medical errors in U.S. hospitals. The 98,000 number was derived by a single report that retrospectively analyzed a sample of charts from several New York state hospitals in 1984, 16 years before the Institute of Medicine report was published. But regardless, the report found approximately 150 deaths that occurred due to potentially preventable causes, and then extrapolated this number to the number of patients hospitalized, not in New York, as the study looked at, but in America in 1997, and arrived at the 98,000 people number. Now, the New York Times, they didn't mention all those details, but they were quick to mention in their report that this is the equivalent of nearly 3 jumbo jets filled with patients crashing every 2 days. Almost overnight, patient safety organizations, both private and government funded and controlled, would spring up, attempting to put their stake in a system-based approach to once again try and satisfy our ongoing thirst for excellence. In summary, what we've really seen emerge over the last 2 millennia regarding quality in medicine has been the transition from a physician's individual focus on humility and personal virtue to a professional society's collective concern built upon the emphasis that medicine is an empirical science, and finally to a system-based approach with a myriad of both new and old stakeholders, with arguably the most powerful one right now being our federal government. Last year, government-funded health insurance, specifically Medicare and Medicaid dollars, comprised about 39% of personal health care expenditures in this country. And I get it. I get it. If you're going to pay for something, you want to know what you're actually getting. And one way to do this is to regulate production, or for that matter, just design the product entirely yourself. Implement a takeover. There's really only one foreseeable problem with that from the business perspective. How good are you at doing what you're trying to take over? How good are you at doing it efficiently? We all want quality, and to be honest, we've always strived to find better ways to deliver it. But our history with quality in medicine over the last couple of millennia has also had long periods of stagnation. And the question that we must ask ourselves now, are the current methods being employed? Are the current methods actually missing their mark? We'll revisit that question shortly, but keep in mind, no one doubts that measuring quality is challenging. And why is it so challenging? Because as Dr. Michael Akkad eloquently explains in a number of his short essays, medicine at its very root is about healing. And healing encompasses both the body and the soul. You see, the aim of science is to acquire knowledge. The aim of medicine? I told you, it's to heal. And these two things are not one and the same. Now don't let me confuse you. One way you can heal is to use scientific knowledge that you believe you've obtained by observation and experimentation. It's one of your tools, but it's not the only one. In fact, personal involvement through caring may work even better sometimes. But that's so hard to grasp. It's hard to measure because it deals with the soul. Now I don't want to lose you here with philosophy, so I'll make my point more direct. In order to assess quality in medicine, you have to start by making 2 assumptions, both of which are inherently inaccurate. Values are the same for everyone, and data is absolute. I'll say it again. Values are the same for everyone, and data is absolute. Let me explain. To declare that the same therapy should be provided to all. To claim what's good for the group is always good for the individual. You must be able to assign scores to the things that patients value. And these scores, if our therapies are to be standardized, they must be weighted the same for everyone. We must make the assumption that quality can be defined similarly for each unique patient, and this assumption is erroneous. Quality for you will never be the same as quality for me. For example, you're feeling weak today. It's because you are anemic. Your blood count is low. I'm your doctor. I know that. And I think you need a blood transfusion. This should improve how you feel. It will provide quality to you. But you don't see it that way. Your ideals are different. Your perspective is unique. From your viewpoint, a blood transfusion places impure substances from outside your body into your body. Giving you this transfusion is not quality to you at all. It's detrimental to a more important value judgment. I had an interesting discussion with someone recently about quality in medicine. We agreed that value is challenging to measure, but I was told that mortality is not subjective. I answered this individual by reminding the person that how you live your life is. And you don't have to just delve into religious preferences to see this fact running rampant. Values just aren't the same for everyone. That makes it so hard to put a formula into it. But even if we had the same values, even if we had the same values, and this is an inaccurate assumption, but if we did, how are you going to measure those values? By using scientific data? It sounds reasonable. Data that's absolute? Sure. Then show it to me. Because as Dr. Robert Centaur reminds us, the philosophy of logic says that it doesn't exist. If X is a direct and logical conclusion of the evidence, different panels of experts would arrive at the same guideline recommendations for the same clinical problems. But this doesn't happen. Different panels develop differing guidelines all the time, and many times they strongly conflict with one another. You need this screening test. No, you don't. How can this be? How can this be? It's because evidence is never absolute. Data must be interpreted. And how do we interpret it? By using our own unique value system. One of my favorite examples of this, favorite examples of the wide discrepancies with data interpretation comes from our landmark clinical trial in my own field of cardiology known as the COURAGE trial. This trial enrolled folks with heart disease, people with a blockage in their heart artery. And they were treated either with procedures, like the placement of a stent, or with medical therapy. Stents versus medicine, if you will. Here's one headline that appeared in the lay press summarizing the findings of this study. Stenting is not superior to medical therapy. Now here's another one from a different source about the same trial using the same data set. Stenting is superior to medical therapy. Which is right? Well, they both are. How is that? Well, it depends on how you value superiority. Do you care about lives saved, or symptoms relieved, or quality of life surveys? Do you want the competition between the groups to end at 3 years or at 5 years? Does it only matter to you if statistically we're 95% certain that the results did not occur by chance? Or are you okay if just 90% certainty exists? Does it change your perception if I tell you that 1 out of 3 patients in the medical group, in the medical therapy arm, didn't actually get medicines as just a therapy? 1 out of 3 actually underwent an interventional procedure, like a stent, during the study, just like the stenting group, yet their outcomes were counted as if they were in the medical group. Because that's the type of statistical analysis that we chose as being valuable for this study. Does your opinion about the conclusions or using the conclusions of this trial to establish guidelines for everyone in town change if I tell you that 94% of the entire population, 94% of the entire population screened for this study weren't enrolled? Only 6% of the people actually underwent randomization and enrollment in this particular trial. I could go on, trial after trial, but the conclusion is the same. There is no absolute data. There is only interpretable data. So values aren't the same. They're not the same for everyone. Data is not absolute. Medicine is not solely an empirical science. But just for argument's sake, just assume these things are true. Then derive a formula to measure them. Oh, wait a sec. That's what we've been trying to do a whole lot in the last few years. The government's takeover of quality in medicine has established all types of formulas and quasi-quality metrics, and the government has levied all types of financial penalties on physicians if they don't comply. Tons of resources are being devoted away from actual patient care to charting and submitting one variable after another to a central bureaucrat for analysis. I think the best question then to ask ourselves now is, how are we doing at that? Are our incentives positioned in such a way that appear to be making a difference? Or are the current incentives weighted in such a way that they are actually creating more obstacles in our quest for quality? Take, for example, your cholesterol. Specifically, your LDL is 70. That's great. Or is it? I'm not sure. How much value is that number really providing you? And is it value for whom? You or the pharmaceutical company? Or me, the doctor, because I get credit for healing you when it's at this level? Major experts can't even agree on this one. And it will likely change again next year, even if values were the same, data were absolute, and medicine were only a science. You can't evaluate quality at this time by tracking micromanaged measurements 10 parts removed from absolutely anything that matters to the patient. It's like trying to determine how advantageous one particular butterfly might be to weather patterns halfway around the world by charting its speed by which it flaps its wings. You should throw out metrics like this one and dozens upon dozens of others that have no role being tied to physician payments. I've been on the front lines of patient care for over a decade now. I know the quality of data that has been submitted and still is being submitted in the name of patient safety. In fact, I literally have quit reading retrospective studies of claims-based data that's been submitted to our government. The information by which their conclusions are based is just unintelligible garble. Now, you can argue that we just need to keep pumping more money into this project until we get it right. Just need more institutes of value, more missionaries for quality. You may have seen this slide before. It charts the percent growth in administrators versus physicians. Over the last 4 decades, the administrators, they're in yellow. The physicians, you might not be able to find them, but they're the smudge of a line at the bottom of the screen. When did the two colors just explode in divergent ways? In the early 1990s. For around that time was when the passage of the Medicare fee schedule took place, with its use becoming mandatory in 1992. Payment for medical services suddenly became highly dependent on an extravagant scheme of codes invented precisely to convey to the remote government bureaucrats what is going on in the privacy of exam rooms and hospital bedsides. And we can keep doing more of this. We can bring in more people to develop and decipher more codification. In fact, in recent years, about the only thing in medicine that hasn't been moving towards a philosophy of less is more is the bureaucratic mandates. For example, my group Private Practice has already devoted thousands of dollars and vast resources to prepare for the likely implementation later this year of the most Byzantine cipher system to date, ICD-10. Every patient's note in my electronic medical record now requires on average an additional 1 to 2 dozen extra clicks on the screen. Every one. And now we can keep doing more of this. We can keep pumping more money into building more clicks in order to measure more quality measures and quality metrics founded on erroneous principles to yield more unintelligible facts to exploding numbers of central bureaucrats placed in charge of determining the health of a population. But for the value of what? Or rather for the quality of whom? The individual. The government-funded health insurance plans, the government lobbying big businesses of healthcare. Or maybe, perhaps, real quality is just about creating ultimate accountability. Maybe the latter is all we are seeking. Accountability to patients that I, as their doctor, out of personal humility, will do the very best that I can every day in medicine for them. And you better believe there are better and less expensive ways to show accountability than what we've done in recent years by attempting to measure pseudo-quality metrics. Maybe my 11 years of medical training after college is not enough accountability for some people. I don't know. Maybe medical board certifications matter. Maybe not. All I know is that I've never once had one of my patients actually ask to see any of the 5 board certifications that I paid money to obtain. I've never had one of them ask me how many of my patients have an LDL level less than 70. I guess that I must achieve accountability to them by some other means, which is precisely my point. 86% of healthcare leaders recently surveyed said their meetings are a waste of time. I am a healthcare leader, and I've been to some of those meetings, and I'll share with you why I believe they have become meaningless. Government-influenced ideas for quality. They've got a number of names, and nearly all have an acronym. PQRS, MIPS, ICD-10, MU, APM, and so on. The vast majority of what we are doing in modern-day healthcare meetings is self-proclaimed futility. Our focus is not on the patient directly, but instead it's on a bunch of acronyms. You remember the Institute of Medicine's report at the turn of the 21st century that alleged 98,000 deaths per year were due to medical errors? You remember all those patient safety organizations who have been established since then? All these checklists that have been created. All these central bureaucratic employees who've been hired. And all of these government-driven so-called quality mandates. Well, let me tell you this. A more recent study in 2013, using just as fuzzy math, I might add, as the Institute of Medicine's report did, claimed that we're now at 440,000 deaths per year in America due to potentially preventable medical events, with an apparent five-fold increase in medical errors. Since the advent of the patient safety and the government quality takeover movement, one may wonder if our methods, the methods currently being employed, are not themselves part of the problem. In confusing the patient with the jumbo jet, as Dr. Akkad says, are we needlessly distracting healthcare personnel from their most precious and unpredictable cargo? Is the government's takeover of healthcare quality actually leading us to the biggest medical error of them all? Has our focus away from the humility of the patient-physician relationship and more toward prideful and poorly measurable outcomes caused us to lose our sight in medicine? Have we lost our focus on the patient? Thank you for your time. I'll be happy to address any questions.
Good morning, Dr. Bilhartz. Can you hear me?
Good morning.
Hey.
I can hear you well.
Thank you for joining us. My name is Dan Cravat. I'm an orthopedic surgeon. To my left is Dr. Lisa Chu, and to my right, Dr. Judith Thompson.
Hey, thanks for having me today.
Well, thanks for being here. Let me just first tell you, that was such a powerful talk, and I've read your blogs and articles through the months, and you have a unique way, a gifted way of communicating to the public, even for those who are not in medicine, these issues and truths that we face in healthcare. So I just want to thank you for that and for your leadership in that area, especially with regards to quality. So thank you.
Appreciate it.
So, yeah, I totally believe in everything you just stated and what to do about it, right? I have this sense that healthcare policy experts, the government, I think healthcare scares them in some way because they can't control it, but they think they have this idea that through algorithms and standardizations and all of these things we can control, that things will be standardized, and you speak against that. But what do we do to have them see things from our eyes, other than someone like you speaking up very powerfully? But what do you think about all of that?
Yeah, I wish the solutions were easy. I'm been excited about this webcast all week and the conference that you guys have set up for that very purpose. I mean, I think we have to start somewhere. You know, my feeling is that we got to get back to the basics. We got to get back to trying to find ways that we can demonstrate our accountability that are outside some of these metrics that all of us that are participating in them almost universally feel like they've started to detract from what we're doing. And I think those are the challenges. And I wish I had all the solutions to tell you guys about. I don't, but I do believe we've got to start chiseling away at some of these things that seem to be bogging down the machine. And sometimes, ultimately, if you, I don't know if we're to the point yet to give up on the machine. And what I mean by that is give up on government-funded, healthcare endeavors. I struggle with this as a physician myself and a private practice physician, but I mean, are we to the point where, the train's going and it can't be stopped, and, physicians have to, unite together and almost abandon that train? And sadly, that would create two tiers, I think, of medicine, and many would argue that we're already there. But again, those are the challenges I think that we're all dealing with, and I think most of us still would like to try to reverse the direction things are headed, but it's going to take going back to the basics. And I think that starts by just removing all of this fluff, all of this stuff that is now tied to physician payments and obviously penalties and everything like that.
Yeah, and we've been, just to kind of continue with that thought, we've been talking the last 2 days about what can be a frustration if someone like yourself is speaking up, and within your own community you hear like, yeah, Rocky, great job, that you said what we feel, but then there's almost a disconnect, and I don't mean to be harsh, but there's a disconnect sometimes with our physician colleagues who tell us that in one moment, but then in the other moment, I don't see any step up in activism, and I really think that's where we need to get as a medical profession for the benefit of our patients and healthcare in general. And so how do we do that? How do we kind of, other than just keep speaking and speaking like you're doing, any thoughts on that?
Yeah, so, obviously you heard sort of my talk and how I feel like our whole principle system now, where we're trying to track things with these batting averages and this thing like that, I think it has good idealistic hopes. It's not working right now. And so, I mean, short of advocacy efforts that I know this is trying to generate, short of advocacy efforts that would essentially just overnight eliminate ongoing meaningful use, or just put that on hold, because we all know it hasn't been very meaningful, and advocacy efforts that could overnight eliminate, any of these physician payment ties to the PQRS measures. I mean, short of advocacy efforts that can do that, I don't know necessarily how to further proceed. And I've watched some of the talks this week. I've watched most of them. I'll review most of the webcasts, the rest of them this weekend. But there's this focus, of course, on the electronic medical record that I think is a fantastic focus from the standpoint of doctors trying to sign a petition to get it out there that, look, this medical record is not helpful. It's in the physician's perspective, it's like the pilot crashing the plane into the cliff. I mean, if we don't change this whole tie to billing and this focus where interoperability somehow has become emailing an 80-page office note or office notes to people that has nothing that really matters anymore. I mean, if these things aren't changed, if overnight, we don't have the advocacy support to say, look, the physician documentation guidelines is 48 pages for CMS. Throw that stuff out. I mean, this review of systems all the time. When it's useless or futile, throw it out. Bullet points, exam points. I mean, throw it out. That's nonsense. What we've got to get back to is the patient, the physician, building the notes that deal with that. And short of advocacy, I don't see any other ways to get any of those things done. And then I do feel like we're getting to a point, though, where if they're not going to work with us through advocacy, I mean, I'm talking our government, I'm talking, the Department of Health and CMS, if they're not going to work for us or work with us on these types of things and work with us now or emergently, then we as physicians have some difficult decisions to make. And you heard from speakers yesterday and the day before about some of the free market stuff, and I think all that's intriguing. And I think it's we've got a physician talking this afternoon that's most recently in the last week written the 12 steps to sort of taking back how physicians should heal themselves. We'll hear about that a little bit later this afternoon. So again, I think all of these things are what we're all dealing with. I wish Dan had all the answers. I don't, but this is where I'm at, and you know, I'm involved. I'm passionate, and I'm like you, wanting to look for ways to change things. But we're going to have to literally bring it back to the basics.
We'll keep preaching it, bro.
Rocky, I love what you described as the evolution of medicine, from of it, which were about the unique perspective of each human being and individual sitting face to face, to this sort of big mechanical infrastructure we have now. And it really, I encourage you to watch the Unique Self-Medicine talk this afternoon, which resonates a lot with that. And so my question is, how does your conversation with a patient change when you acknowledge you as a unique perspective and the patient having a unique perspective? And can you together define what quality is for the two of you?
Rocky?
And, you know, I think that's our challenge, right? So what's truly quality, I've written some stuff on this before, but I mean, I literally believe that, you know, you could come down to my clinic. I just finished up clinic. You could come down to my clinic. You could literally be a part of my environment for 5 minutes. And you could be the patient in the room, or be a bug on the wall, or something to observe things. And literally in 5 minutes of sitting in my exam room, listening to me and dealing with my interaction with the patient, I really believe you would understand more about the quality and more about the value that I provide as a physician than any numeral number of these sort of things we're trying to measure. And again, maybe that means the quality is that challenging. There's so many intangibles that exist. But, you know, at the end of the day, quality is different for everybody. And it's my job as a physician to figure out exactly what their values are and what they, you know, what until everything relates to each other in medicine. And then once you build that accountability and build that trust with a patient, the patient wants you to assume their health risk with them. They want that. And that's what medicine's about, that patient-physician relationship. That's quality. I just don't think any of these check boxes we're doing, any of these numbers and figures define that at all. And I think real quality is accountability. How do you obtain accountability? Well, you prove that I have a skill. You prove that I have been trained well. I don't know what that is. Maybe that's medical school. Maybe that's residency. Maybe that's training. But ultimately, you decided that I have a skill that I'm offering to you at some level. And then you give me a license because I have that skill. And so, you know, I have the legal, I guess, support to provide the care that I'm providing. And then you do and tell me to, or force me to do certain things, or require me to do certain things I should want to do anyway, to continue or maintain that license. And so, you know, there's some things that relate to that, but we've blown way out of scale. We have so many different organizations right now that are providing oversight, and it's really got a little bit confusing. But from the standpoint of like real quality and true accountability, you know, the best thing that ever happens for one of my patients is when I discuss their challenging case with one of my colleagues, or maybe two of my colleagues, or literally maybe 5 or 6 that I send a message to, or I call on the phone, or I exchange some imaging data. I mean, that's where we find out what each other knows, does, seek second opinions. We learn from each other what works, whether that occurs every year at a medical conference where you learn from others what they're doing, what is working, you get the data. I mean, these are the types of things, this continuing medical education, but amongst our peers, that I think is the most helpful thing regarding maintaining our accountability to our patients. But then at the end of the day, if I'm trained with, and I'm licensed to do this, and I do these things to maintain the license that I just kind of spoke with you about, then you have to let me practice medicine. And that's how I'm going to be the best doctor for you. That's how I'm going to provide the best quality.
So, Rocky, Judy Thompson, General Surgeon, New Braunfels, Texas. I've read some of your blogs. I think you and I have had some brief correspondence. We have a comment.
Hi, Judy.
Hey, we have a comment from the audience, and it says, "Excellent, Rocky. The increase in the number of administrators directly has amplified this problem. Solutions are clearly a challenge. Still, I feel follow the money." So whoever wrote this believes that perhaps if I interpret that as, if we'll follow the money, maybe we'll identify the problem, and from there can begin to develop a treatment plan.
Okay, and I guess I'm still following a little bit. So if you say track where the money goes, like what do you think the audience member is getting at regarding that?
I can go ahead.
I'm not sure. That was my question as I was reading this comment in live time. I'm not sure where they were going with follow the money myself.
Well, I'll put my own interpretation on it.
Go ahead.
I think if Michael were here, he would bring up the High-Tech Act immediately. It's something he's passionate about. The government made money available. Some businesses identified that money, that source of money. They took the steps necessary to get the money, and the steps that they took were defined not by physicians and care providers. They were defined by maybe politicians or people on political committees. So if you were to follow that money, you would find the source of the problem, why we have an electronic health record system that doesn't meet the needs of physicians, but may meet some defined need of, I'll say, politician or policy person.
Right. I mean, I think I mentioned this briefly in my talk, but going back to 1992, 93, early 90s, I mean, that's when we started collecting all of these codes that in many ways are ways we can, demonstrate to someone else who's off-site, perhaps a bureaucrat, administrator, whatever, what's going on in the confines of our offices, right? And so a lot of what seems to have come from a physician perspective over years is just, things that tend to have lost focus with what's really going on here at the ground level. And, I mean, I think it's all good and grand that, we have $30 billion that we want to devote towards some project, but, my personal opinion is that, when you artificially stimulate some markets, you end up getting a lot of people that survive, a lot of companies and businesses that survive, in my opinion, producing subpar products. And part of the reason they were producing subpar products is they were trying potentially to be honoring the folks that were giving them this $30 billion, which feels so disconnected from what's really going on at the ground level. So, I'm not certain, that artificially stimulating a market like that has really been helpful, because we're literally to a point where we want to break down all of that we've set up with this electronic medical record. I don't know if anyone's happy with their electronic medical record, and some people might be, but there's still just so much, so much fluff. I describe it as monkeys on a typewriter half the time, and this is the data that you end up getting when you seek it from, an outside facility. It's just a bunch of stuff that's not helpful. So, that was our whole, first day of this webcast here at the summit, was really talking about how to change the things from the electronic medical records. But I'm not sure how helpful that $30 billion has been to this point. I'm not telling you that it didn't sound like a good idea at that time, but right now it just doesn't appear like we've achieved the things we're trying to achieve from it.
Hey, Rocky, Dan here again. I have a question for you. I sometimes think it's worthwhile to take a step back, and I try to put myself in their position, healthcare policy experts in the government, and how they're viewing all this. And I think the perspective they're coming from is they look at healthcare in general, and they see wide variations in treatment based on geographically where you're at, and they see differences in pricing, and they look at all this and they go, come on, there's got to be standardization here. Where is it? But what they fail to understand, what you spoke so eloquently about, I think, is that not everything, in very fact, few things in medicine is black and white in terms of the science of it. But at the end of the day, we all look at things from our own training perspective. We try to do the best we can, and therein lies the reason for some variation, perhaps. But that's how they're looking at it. They see the cost going up, and this is their answer to it. Thoughts?
Yeah, I agree with all you said, and I don't think anybody, we can be critical of where things are, but I think everybody admits it's complicated. But likewise, I'll throw out there that medicine's done different ways, different places in the world, and the care you get for a hurt arm or or a, you know, broken bone, perhaps even in America, is different than what it might be in Beijing, or maybe it's a little different than what it might be in London, or maybe it's a little different than what it could be, you know, in Rome. And so, you know, there's regional variations all the time, and I think a lot of that plays into cultural value systems and everything that kind of we talked about. So I think it is challenging. I think we all admit that there's no simple answers, although I actually think almost simplicity is the utmost sophistication. And I think we've gotten to we've tried to be too sophisticated now in trying to assess things. And I think the more that we can chisel down to get back to that patient-physician relationship, the better that we're going to be. I don't have all the answers either, Dan.
So, Rocky, we have just maybe a minute or so left. I have a really exciting personal example, which I think exemplifies the things that you have said. This happened years ago. This was a young lady. She was relatively healthy. She needed a hemorrhoidectomy. We made preparations for surgery. And in between the visit, when we scheduled her surgery and her surgery, she returned to the office. And I said, "What are you doing here?" I thought that we had answered all of our questions. And she said, "I failed to tell you that I'm a Jehovah's Witness. And in the event that there is bleeding, I want you to know that I don't want a blood transfusion." And I told her that I respected her religion and I respected her point of view, but when I'm in the operating room, I am the surgeon. And I'm the only one that makes a decision about how I practice medicine. And if she was not comfortable about the decisions that I would make in the operating room, then she would have to find another surgeon. And her reply to that was, "You have told me the truth. And because you've told me the truth, I trust you. And I'm going to stay with you." And, you know, to me, that just hit the nail right on the head, you know, in terms of, yeah, letting people know what their options are and then letting them make the choice that's best for themselves. She easily could have found somebody who would have been compliant with her point of view, but she chose truth and trust.
That's right. And I think that is what patients want when you really boil down to it. And so much of this other stuff is other people trying to put words in someone's mouth what they really want. And, oh, the patient wants these certifications for the doctor and the patient wants this. I just don't really see that being a reality in real practice. What the patient wants is you to be there for them. They want you to hold their hand. And I do think they ultimately want you to make decisions for them after you convey that trust to them about things. And so, anyway, I love your story.
Thank you.
Hey, Rocky, we're just about out of time here, but let me just thank you once again, and let me encourage you to keep speaking out how you're speaking, because you are right on and you are gifted in how you say things. So I know for a fact it takes more work and it's a lot of effort and it's more time away from your family. And please don't get burned out. We need people like you in the medical profession. And so I would just applaud you and encourage you and keep up the good work you're doing, okay?
I appreciate it. Onward and upward.
All right.
Take care.
Thank you.
Yeah.
You have a good day, okay?
Bye, Rocky.